Okay, welcome everyone to our third webinar speaker series. We have Dr. Fabio Almeida, who's an assistant professor in human nutrition, foods, and exercise at Virginia Tech, as well as the principal investigator of an NIH-funded study called diaBEAT-It. He's going to share the design and methods, current status of the project, and future directions. We have a lot of guests on the call, so we're very excited you're joining us. We also have large representation from our REAIM work group. You can see the full list of those members on the reaim.org site. And then we have a bunch of guests who are joining. Feel free to ask any questions in the chat box or via audio when we end the discussion. We are recording this session so that we can post it onto our REAIM home site as well. So I will let Fabio take it away. If you experience or see any technical difficulties that we might not be aware of, please feel free to alert us to that as we progress. So I will let Fabio start.
All right. So first, can folks hear me? I'm assuming that folks can hear me okay. First, I want to thank both Samantha and Paul for inviting us to come and talk about our program. And as Samantha said, that's I'm gonna talk a little bit. This is a work in progress, so keep that in mind. I will be sharing some of the design and methods that for the project itself. And but if you want to get more details on the designs and methods and all of those things and some of our more in-depth decisions, we do have a paper that came out last year. I do have the we have the reference right down here on that first slide, and then I can also send it out to folks. And I believe Samantha sent that paper out to the work group, right? So the work groups should have that paper as well. And as Samantha said, it's a R18, so it's a translational grant funded by NIDDK, and it's a 5-year project. So my understanding is that we have about 30 minutes, give or take, and I know a little more, so I'll try to speed up through some of these. And we can have some questions and answers at the end. So let's see if we can get this here to move to the next. No, okay. Maybe I have to click in there. No, don't close because I closed the recording. There we go. Okay, we'll just click on the. So first things first. This is as with most translational projects in our project, it's a team collaboration, and I always like to acknowledge all of the collaborators. We have our investigators, we have our research staff and students, and all of those folks that allow us to do the type of work that we do and take care of the day-to-day. We also have both. It's our project, as you'll see clearly, is a partnership between Virginia Tech and Caribbean Clinic here in Roanoke. It's funded by the National Institute of Diabetes and Digestive and Kidney Disease, and we also have the support from the Freyland Center for Translational Research, Obesity Research as well. And I always like to do a quick special thanks to Aaron and Cam. Aaron's our postdoc and Cam is one of our PhD students. They are the folks who are responsible. They're the culprits in putting the slides together for me. They helped through the entire process. So everything that you guys see that you really like, they are the ones that you have to, they're the ones that did that. And anything that doesn't quite work or is out of place, that was me trying to change things in the last minute. So anything that doesn't look quite right, it was me. Everything that looks great, that was them. So, and as usual, I always like to thank our research participants and the families that take part in the project. So a quick outline what we're going to talk about today. I'm going to do a quick introduction and I'm just going to breeze through that. That's the usual things. Then I'm going to spend some time on the design and methods and how we used the REAIM framework to help us both in the planning process and through the implementation now, and then how we're using for the evaluation as well. Then I'm gonna spend some time just. There we go. as I was saying, quick outline, we're going to go through the introduction, study design and methods, and then I'm going to talk a little bit about where we are right now, and then briefly touch on some future directions. And then after that, we should wrap us up in about 30 minutes. I'll try and keep it to the 30 minutes as, or even less, as Samantha has asked me to. So without further ado, quick introduction. We all know that the diabetes prevention, the prevention of diabetes it's a major public health priority. And then, in fact, not just in the U.S., but throughout the world. And that's because of the rising prevalence, the rising cost associated with it, and the lack of a known cure for diabetes. In fact, we have nearly half of the U.S. adults have diabetes or prediabetes, and most are unaware of. In fact, over a quarter of people with diabetes, they have no idea that they have it. And more, and even worse, about 9/10, so 9 out of 10 folks with prediabetes in the United States also have no idea that they have it, where we kind of talk about this idea, this iceberg where we have, the folks with diabetes on top there, currently about 28 million, but then we have all of these folks who over 79 million that do know that they have that could eventually turn into diabetes. We know that diabetes leads to this a huge health and economic burden due to the rising risk for heart disease and strokes, the leading cause of death, both in the US and around the world, and it costs over 245 billion in annual costs here in the US. So we do know that without intervention, whether it is through lifestyle modifications or medication, people with prediabetes can develop diabetes within 3 years. So our goal is to really look at this from the standpoint of, what can we do to prevent diabetes, so we can prevent this, because once people have developed into diabetes, there's no known cure at this point in time. And so that leads us to, as a response, we've had several different programs that have looked into it. And one of the most successful ones, and it's the diabetes prevention program that came out in 2002. And around at the same time, or roughly before that, the Finnish DPP came out, I believe it was 2001 or right around that date. But here for the US, the big one was the diabetes prevention program, was the first large-scale multi-center randomized controlled trial, had over 3,000 participants, 27 clinical trials throughout the United States. And we can see there on the slide, the field, some of the different places where those clinical centers were. And the goal was to find out if weight loss through diet and exercise or drug therapy can prevent or delay type 2 diabetes. And the key findings there were that lifestyle intervention was able to when compared to the placebo, that was able to reduce the diabetes risk reduction and prevent the further development in diabetes by 58%. But not only that, not only it worked better than the placebo, but it worked better than the use of metformin, which is a type of drug also used for that. And the original DPP used a 3-year evaluation period, and then they came out with the group in the Lancet 2009 when they looked at the 10-year follow-up, and those effects, they still saw that 10 years after that. So we do know that lifestyle interventions can be successful in helping prevent and or delay the further development of diabetes. So that led to a lot of folks trying to, once we recognize that lifestyle interventions are in fact a potential and are effective in this way of preventing the onset of type 2 diabetes, then there's been a huge amount of effort into translating the diabetes prevention program into practice. In fact, there's been several reviews, but there's a recent review by Ali and colleagues that they indicated there's over 28 different trials here in the United States based on the DPP. And all of those trials are trying to either translate the DPP, they're adapting some of its core elements to different settings, to different locations. And they all kind of share some of those traditions, some of the core elements that they look at include things like the frequency of staff contact, social support, self-efficacy, self-monitoring, problem solving, individualized program. They usually use some sort of a combination of the 16 different sessions that the original DPP had with the content. They look at goal setting and some of those things. A lot of those translational DPPs, they have also shown that have been effective in weight loss. We have some good evidence from programs being translated to YMCAs. We have some that they're being effective in the weight loss. They have some that have used primary care, some faith-based organizations, telephone, and DVDs as well. However, there's still a number of information on factors that are necessary to translate these findings into practice. And when we talk about translating these findings into practice, not only us testing to see if the DPP works under these different settings, but what are the things that we can do to make sure that when we initiate these programs under these different settings, what are the types of things that we can do to make sure that that program will be sustained over time? And also that program will reach those folks who need the most, and then also that program can be easily adapted and implemented and maintained over time. So those are some of the things that we still don't know. There's more information needed, and then that is highlighted by a little bit of that science to implementation gap that we can see. So how do we go about translating some of this evidence-based program, which is the diabetes prevention program, into clinical practice? We can use several different frameworks. We can use models, and we can use different dissemination implementation strategies to try and help us kind of think through and think of ways that we can best develop these programs in order to be able to ensure that they will be sustainable. They are adaptable and they can be sustainable over time. Russ and colleagues, they started with the REAIM framework back in '99, and basically the idea of the REAIM framework is kind of provide this framework, this model for us to think this balance between internal validity and external validity types of indicators and types of factors that can help us in assisting in this translation process. And then the REAIM indicates that we have five different dimensions that together they contribute and they impact in different ways for this process of translation. I'm not going to spend a whole lot of time on REAIM and all of that because most of the folks in this call are fairly familiar with the REAIM. So we're going to go on to the next slide where I talk some more about how did we actually apply that. So for our project, here, one thing that the slide doesn't quite show is, and then the paper we do talk about somewhat a little bit that process. But one thing that this slide doesn't show is that we've also engaged in a systems process where we collaborated with both with our practice partners here at Caribbean Clinic, as well as we reached out to the potential participants for our programs. And the reason that we did that before we started the planning process, during the planning process, was that we wanted to make sure that once we develop our strategies, once we develop the types of program that we're thinking, that we would have the best chance for the program to reach those who need the most. We wanted that our program to be able to be adapted without losing its core components of the DPP. We wanted that it could be scalable enough throughout our healthcare partners here throughout the system. So throughout that process, we identified when we think about reach. We reached out to our to potential to patients here within Korean Clinic. We asked, we talked to them about different types of programs, different frequency of program, of potential interventions, different ways that we might be able to reach out to them, best ways to communicate with them. And we've also, shameless plug, we've also published a little paper on that last year as well. So that was kind of part of us kind of looking at the reach before we started the process. And within the project, one of the things that we want to look at is, what is the potential reach of these interventions that we're adapting, and what can we do to reach as high a proportion as possible of those folks with risk for type 2 diabetes. We also want our program to effectively support our patients in reducing body weight by at least by 5% at 6 months, and we have actually set a higher goal of 10% at 12 months. And I'll talk some more about that a little later during the design slides. And the idea here is that how can we, make sure we're also looking at quality of life, and I'll talk some more on the other effectiveness and different dimensions later on as well. As part of the adoption for the project, one of the things that we did, while we're not at this point in time, we're not necessarily intervening, on the adoption dimension. One of the things that we've done is kind of work very closely with our partners here at Korean Clinic, and to identify, what are the best strategies that we can use to make sure that once we get the program off the ground and that we can implement the program throughout these different clinics, that they could potentially be adopted across all the healthcare settings once the research funding is done. So that's one of the things that we've done beforehand. But for the project itself, we're just keeping track of some of these different factors. And then on the implementation standpoint, we want to make sure that our programs, the programs that we've developed, that they can be implemented at a reasonable cost. We know that cost is always an issue. And when we talk about cost, we're not talking about just the financial cost, but we're talking about personnel cost, resources, and different types of resources, locations, and all of those different costs that sometimes they go that we can eventually calculate into a financial type of a cost, and we will be doing that. But we also have to think about what types of resources, what types of clinics, what types of personnel are available to implement the types of programs that we want to do. And not only that, we wanted to also to make sure that as we develop the program, we wanted to make sure that our program not only led to weight loss, but we wanted to make sure that people can maintain that weight loss. And as I mentioned, we also want to make sure that the program would be able to be sustained in the typical healthcare settings, in this healthcare setting, sustained over time as well. So those are some of the things that kind of from a re-aim standpoint, those are some of the factors that kind of guided our process through the planning, now through the implementation and evaluation process. And I'll talk some more through the different outcomes, the different how the dimensions. I go through the design here really quick. So let's look at how do we kind of thinking about using the re-aim framework, and also thinking about this idea that that it is a translational trial, and that is a trial that we want to look and see how can we potentially translate this evidence-based program into regular practice here throughout healthcare, in particular throughout the healthcare setting, in a primary care setting strategy. So how can we do that? So one of the things that was clear for us from the get-go is that we needed to think a little bit outside of the box when we're thinking about designs, right? Because our traditional designs, when we're thinking about randomized controlled trial designs, which are the gold standard, and whenever we do those types of designs, we know that they tend to favor internal validity. They tend to favor a lot of control. And and that leads to actually kind of limits our ability to be able to generalize our findings outside some of these contexts. So we wanted to make sure that we came up with a design where we could balance both, just like the REAIM, we wanted a design that would be able to balance both the internal and external validity at the same time. So one of the things that we came up with was we thought through, and we come up with a hybrid preference and randomized control design. So I'll talk through here in the next few slides. What I'll do is I'll talk a little bit about the actual program and then how we've applied the hybrid preference randomized control trial design. And then I'll share a little bit of some of the materials that we have developed for the program itself. So as the name the name of the program is, as we talked about, is diaBEAT-It, taking action to prevent diabetes. And this was through a long process of a lot of hours of different ideas for names, and we had several different input from different stakeholders and all of that, and eventually we came up with the name and with the logo. It is a 12-month weight loss intervention for adults at risk for diabetes, and we use this innovative hybrid preference randomized control trial design where, and I'll talk through, I have a couple of slides later on where I talk through this two-step, kind of a two-step randomization process in a sense. We have, well, first we identify potential participants, and then for a part of those potential participants, we offer them the preference or the choice design, and the other portion, they go into we only offer them the randomized control trial design, and then we kind of go from there. But I'll talk furthermore here in the next few slides. So our overall research goals, the primary research goals is to evaluate, to determine the reach of each intervention, the number, proportion, and representativeness of those who participate in the program. We also want to determine the effectiveness of the different strategies in supporting a 5% weight loss, and both a short term, which is defined as a 6-month weight loss, as well as 12 months 12 months weight loss as well. We are also determining the cost effectiveness of achieving 5% weight loss. And some of our secondary research goals, including looking at adoption rates of clinics and physicians' approach to participate. We're also tracking the fidelity of the intervention delivery. We have several processes in place to evaluate our protocol implementation and process evaluation and all of that. And then finally, we're also looking at, we'll also be able to look at the impact of the preference design on the intervention effectiveness. So we'll be able to look at intervention effectiveness based on preference as well. So how are we doing that? So a quick study overview. We are shooting to recruit 600 participants. The inclusion and exclusion criteria is fairly broad. There's been a couple things that have been added due to requests from our physician partners, so for right now, it's a BMI is 25 or higher. They have to be adult, or as a definition from the NIH, which is 18 and older. 18 is actually considered children, so it's 18 and older. But the fasting blood glucose around between 100 and 125, or is at high risk for diabetes based on the ADA risk test survey. So I'll go through that a little bit. And that's one of the things that we have kind of modified a little bit as we went through. Some of the exclusions include that if they are currently diagnosed as diabetic, if they are pregnant or planning pregnancy, some contraindication to PA weight loss. They don't have any access to phone, and at this point in time, we're not able to offer the program in any other language other than English. So if they're not able to read and or understand English, unfortunately, we cannot offer the program to them at this point in time. The intervention, and I'll talk some more on the design itself, but we basically have 3 arms. We have what is a standard care group, which is basically a 2-hour small group session targeting key elements of the DPP. And another shameless plug, we have a paper from 2010 that showed the effectiveness of that program, resulting in sustained weight loss even 12 months after the fact, after the program, after that one class. So, and that one class has actually been implemented before we got the funding for the NIDDK grant. That had been implemented here throughout Carilion through their diabetes education program. They had been offering that class already. So we are using that as a standard care because any patients from Carilion Clinic at this point in time, they could, as long as they qualify for that program, they could attend this standard class. For the purpose of our project, we have there being offered some additional classes where we only have research participants taking part on those. We also have, and then so that's considered our standard care. That's our control group for the randomized control trial side of things. And then we have 2 interventions, one which uses the group plus 1 live call plus 22 tailored IVR calls. They're all based on the DPP content, and I'll talk some more down the road. And then we have another intervention where instead of using the class, we use a DVD to deliver the same content and the same information that the class does, but using a DVD format, as well as the same live call and the 22 tailored IVR calls. And here our outcome measures, there have been measured baseline 6, 12, and 18. And I have another slide down the road in the next few slides that I'll go some more over the how we're measuring the different outcome measures by each different re-aim dimension. So I'll talk some more about that on the next few slides. So, so our participants in design. So looking at, so why did we look at this hybrid preference in RCT design? As I talked about, our participants, our target population, there are overweight and obese adults at risk for diabetes, defined as a BMI greater than 25. And here on the side, we have that's the risk test, the ADA, the American Diabetes Association risk test that we use to determine the risk. And basically they have different questions around age, different risk factors, and then you score folks, and then folks who score 5 or higher, they're considered to be at a higher risk and should see their physicians as soon as possible to see about the potential of testing and so forth. Now, one thing that I mentioned that we had to modify a little bit was because as we started the process of recruitment and going through the screening process, one thing that we noticed is because of the way that the diabetes risk test is, the way that it's scored, we noticed that the risk test was systematically excluding folks that could potentially benefit from participating in the program. And in particular was because those who are younger, females, and if they had never been, they have never been pregnant before, but they were still obese or severely obese, they were still scoring a 3 or a 4 on this risk test, and then they're being systematically considered not eligible for the program. So in consultation with both the NIDDK and our physician partners here, it was decided that we should, they asked us to, instead of using this risk test as an exclusion criteria, that we use it more as a more of a screening, not as an inclusion criteria anymore. And then we've changed our inclusion criteria ever since then for overweight and obese patients of a BMI, 25 or higher at this point in time, and with some of the other risk factors as well. And we have some more information on that on some of the other papers. Now, for the hybrid design, why did we think of the hybrid design? The choice, the preference design allows us to talk about this idea, to look at this at different issues related to external validity, related to what you would actually see and is represented by the usual patient on their regular day, where any individual usually have, they have choices, right? They have choices as to what type of treatment they might want to engage in. They have choices as what type of medical care they want to seek. They have a choice as to, if I want to go to a program or not, if I want to go to, if I want to take medication or not. So part of the preference design gets this thing that we're able to offer patients when we offer them the opportunity to participate in the program, that they get to choose. They get to pick, as the name says, they get to pick what kind of program that best fits their lifestyles, whether it is they prefer to have DVD, watch at home, and they can have access to that at any point in time that they want, or if they prefer to have that person, their human contact with folks, and then through the small group classes, and then of course they receive all the other stuff. And at the same time, on the randomized control trial also allows us to determine the effectiveness of these different programs. We still can keep that internal validity within that, and this hybrid design allows us to kind of really try and balance these two, both the internal and external validity. So a little bit more on the sampling recruitment, and it looks like I have about 8 minutes here, so I'll breeze through some of these here. So we're recruiting through Caribbean Clinic and Family and Community Medicine clinics here in the Roanoke area. There's 12 practices, 237 physicians, over 150,000 diverse patients are served by these clinics. Now the clinics we have on the picture now have way more than 12, but that's that cluster in the middle. Those are the 12 there, and they're all identified through the electronic medical records. And then once we identify them, the electronic medical records, the list goes to we're right now our practice is to go through one practice or one clinic at a time. So we are on clinic number 4 right now, or number 3, sorry. And then what we usually do, we pull their potential lists through the electronic medical records for each clinic. Then we send the list over to our physician partners, to their personal health care, primary care physicians. Then they go through the list, and then they eliminate anybody that they don't believe would be a good candidate for the program. And then for those that they think that we could potentially contact, then we send them letters. Now those letters, we are, as you see down below, we're going to have the 240 participants in the choice group and 360 in the RCT group. So those letters, they're also stratified that way, where we have about 40% of the participants are randomized to receive a choice letter, and then 60% of the potential patients receive a letter and mailing with information regarding the randomization group. And then once they the initial randomization, then they only receive information regarding that potential specific group there. Then we go through the process. We call them back. We call them to follow up. Go through the eligibility process. We have 2 study visits where we conduct the informed consent procedure at the day 1 visits, and then we complete everything else at day 2 visit. And then at the end of the day, you will have a choice group where we have 240 people, and then RCT with 360, and that's all. Then really briefly, as part of, and I'll just go back really quick. So for each of those interventions, we have the class, we have a workbook, we have a teach back call, and we have the IVR calls. So the way it is set up during the DVD of the class, we use the 5 A's model for action planning and goal setting, as well as we go through a lot of content regarding the current. We go through current guidelines for physical activity, healthy eating, and weight loss as well. After that, we have roughly a few days after that class, or when the DVD was given, then we have a follow-up live call where we employ a health literacy strategy of teach back, teach to go, to assess comprehension and make sure that the participants did grasp all the different concepts that were covered both in class or more using the DVD. And following that, we have the weekly IVR or automated phone calls that go through the weeks 1 to 8, then bi-weekly after that, and monthly calls for the last 6 months. And all of those, they matched up with the sessions there and the content areas that the DPP used. And I'm just gonna breeze through this because we are running short on time. Again, the work here is just briefly our action plan using the 5 A's, and we can talk some more about this later, but the idea is that we assess, then we advise, we set goals, and we look at the strategies and barriers, and arrange for follow-up later on. Here's a book, a quick session example. Each session begins with a session overview. It provides a glimpse of the session materials and then provides a guide as to the action steps. Now, during each IVR phone call, we cover one session. So for each IVR call, we have one session on the workbook. So they're built in a way that they follow each other. So you do the IVR call, and then the IVR introduces the concept, and then the workbook then covers in more detail those concepts. And then at the end of every session, we have some homework activities that we talk about being the action steps. So as usual, we have some food and activity tracking logs, provides convenient place for participants to track a variety of health behaviors daily. We track physical activity, fruit and veggies, and later on we add some calories and different health nutrition behaviors as well. So some of our outcomes for each, we're looking at number, participation rates, representativeness, effectiveness. We're looking at weight loss, physical activity, dietary behaviors, and quality of life. Adoption at this point in time, we're just assessing. We're not intervening or any of that, but we're keeping track of the number, proportion, and representatives of the participating clinics, implementation as we talked about, and then maintenance, looking at effects of both 12 and 18 months. So where we are now, really quick, we've sent over 3,000 letters. We've made over 9,000 telephone calls. And yes, those are multiple calls to the same people. To date, we've completed 2,394 recruitment calls. Of those, 17 were unsuccessful. Most of the time, we can't quite get a hold of folks because their phone lines have been disconnected or we're not able to reach them. But we have assessed 636 people for eligibility. Those about 22% are ineligible. 328 have agreed to participate to date. Some of the reasons of ineligibility, the primary is around mental incapacity, condition, will not be in the area. We also have some of the reasons for decline, which is initially they agree to participate, but then they kind of disappear before they ever show up for the day one visit. So that's some of those what we call the passive drops there. And it may be that they're just not sure how to say no on the phone, and then later they realize that they don't really want to be part of the program, and then they just kind of disappear from there. And then some of the characteristics we have here, ineligibles and willing to participate. They're fairly similar, and none of them, again, this is just a very rough cut. We have not run any statistical significance on any of this. This is just intended to kind of highlight a little bit what these folks look like. Then furthermore, we have here, it looks like, the proportion of folks who are eligible, ineligible, not interested by choice or randomized or RCT. However, these numbers are not cleaned up yet, so there's some of these here that they probably won't add up very much. But the idea is that we are currently in the process of that recruitment and then cleaning all of that up. And finally, some of the baseline characteristics, how we're going to be looking at, we've got about 55% of the sample are white compared to Roanoke here, where 65% is white. So we're getting a more diverse population. We got about 61% of the sample being female. Roanoke is about 52, so it's slightly higher on the female. And here we have some of the other characteristics that we can take a look at. And then for right now, effectiveness, we just initiated probably about a month or so ago, we started some of the initial 6-month assessments. So looking in the future, last slide. I know that Samantha is just about to pull the plug over here. And so looking in the future, continue recruitment. We have over, well, the numbers, but we have over 220 people that completed both day 1s and day 2 visits. We have 100 individuals who are currently scheduled. And then our projected end date for recruitment somewhere around August to at the end of the summer this year. We're hoping to get to that 600 there. Retention, as usual, we got 6-month assessments starting now. We'll have 12 months later, and then 18 at the end of this year. We have 20 people that have completed that 6-month assessments, and we'll have more to come. Lots of papers, presentations, collaborations. We continue to talk to folks about different ways and different things that we may want to take this program to different settings, different places, with including talking to some of our partners in Brazil, looking at how we might be able to do some of those things in different locations as well. And with that, I will thank everybody. Questions, comments, and Virginia Tech, thanks everyone for being here with us today. And so that's really how we kind of went through that process. And for most, and if you look at the REAIM dimensions, for most of them, we assess them, right? So like for reach, we're able to really kind of get a better sense of what the reach might be when we use, when you have the option for participating in a program, or when you are, the traditional one that sometimes people, they don't want to participate in a research program because they don't want to be randomized. So they're saying no to being randomized, but not necessarily saying no to the program itself. So this way, we're able to actually get a better sense of the reach by kind of having this idea where and we still might have people that will say, no to even on the preference design, that because we have all the different assessments associated with it, that they may not want to participate because of the assessment. So we're tracking that as well. But I think that that's one of the things, but we're not necessarily intervening upon, in different strategies to amplify or to modify our reach, right? I mean, we're looking at different ways of reaching those folks, but it's more on that. The adoption is kind of similar, where we're not really intervening, we're more kind of describing that process. So I think it was more on when we talked to our partners, and it was a decision around, a lot of the decisions are around what is important for them, what do they want to know, and that's how we made the decisions on those.
Next question from any of our audience members.
And I think we have a chat down here. If you want to type in your question, I think. Is that the one? Okay.
Can you hear me?
Now we can.
Hello. Yeah, this is Russ, Fabio. Great presentation. Thank you. Nice description of the project. I'm kind of struck by how many people that it looks like you lost after they agreed to participate on the phone. And that's something that others of us have seen too. But I was just wondering your thoughts about that. And it looked like you still, even in the choice condition, had to get informed consent. I was wondering if you thought that was due to it, or if it's just logistical issues, or what was responsible for that kind of pretty big drop off between agreeing over the phone versus showing up.
Mm-hmm. Yeah, I think there's a couple things going on, Russ, here. The initial, like I said, we have 12 clinics, and the initial 2 clinics that we have started on purpose, we started on clinics that they serve lower SES population. They serve more of a population that they tend to be less established. So they tend to move a lot, move around quite a bit. So it was on purpose that we started there because that's where our partners wanted us to kind of try and reach those folks first. Now, one of the things that we've noticed with that, with those clinics in particular, is that getting a hold of these folks a lot of times is really hard. And even when we get their telephone numbers and those kind of things, a lot of times when we go and try and contact them again, their phone no longer works. They have a new number, and that contact is not updated in the system, or there's no other way for us to reach them. So we lost a good proportion of folks to that. Basically, that after we contacted them, after they agreed to participate, we send them. Sometimes we double check their addresses and everything. So we send them all the information, and sometimes we get our letters and our information back saying that they no longer live there. Or then we try to call, and then the phone is disconnected. And then we have phones of other folks that we could potentially contact. And then when we contact them, it's like, oh no, now they don't have a phone anymore, and they might not. And so we'll try and get a hold of them. So there's some of that issue. It's a proportion of folks, but not everybody, right? Then I think the other piece, I think that even with the preference design, we're still not able, because as being during the grant process, we were still not able to. We had to get to the whole informed consent process. They weren't allowed to just offer programs as if it was outside a research kind of a setting. I don't know if that's what you're trying to think. So partially it was because we couldn't quite in a sense, get away with not doing the, like the research intensive kinds of things on the preference design. So that was partially, and I think that there is still just kind of looking at some of these initial numbers, and then I think definitely it is. We still won't be able to get this through, kind of look at the reach, because I think there's a number of folks that once they get into it, and once they figure out that they have to come back for over the next 18 months, and they have to come back for 2 visits each time, and they have all of these additional things that they just feel that it's just too much. So I think that that's a combination of factors, Russ, but we are trying to investigate those as well.
Thanks.
Yes.
Can you hear me?
Hi, Deborah.
I have a question, Fabio. This is Deborah. Hi, great presentation. Very interesting. I'm curious about the actual preference, and whether you feel, after this much experience, the amount of experience you've had so far, do they really know what to prefer? Do you feel like you give them enough information so they are making a really well-educated choice, or does it take a certain amount of experience with the different intervention groups?
Yeah, I think, Deborah, from our experience, it really comes down, I think, for them, because all of the activities involved with both programs, they're pretty much the same. So really the choice becomes about, do you want to get the content information? Do you want to use through a DVD where you can take it home? And that's how we describe it, right? When they're here in our office and we're talking to them and we're describing the 2 programs. And then we talk about, here's the DVD, you can take it home, you can watch it anytime you want. You don't have to come back for a class, you don't have to do that. Or you have the class where you have that human contact. You're going to have, the diabetes educators there. They're going to go through all this content and everything. So I think at the end of the day, it becomes about, and that's what we've kind of noticed, it's more about this, for most of the folks, it's about this convenience thing. So if they feel like they don't want to come back, or they'll rather just kind of do things on their own and at home, they'll kind of go towards this, through the DVD. And then if folks that they would rather talk to other people and kind of have that at least some sort of human interaction, because everything else is all technology based, then those it seems like that's the choice they're making. But I see your point. How much do they really understand, and do they really know about the difference between the two of them? It's that's part of what we're trying to look at with the teach back, teach to go, to see whether how much are they comprehending. Some of the initial kind of a very brief looks at the data that we're having, it looks like it's across the board over 80% has somewhat of a higher literacy rate, health literacy rate. So it indicates that that's a more literate, kind of like health literate population that is taking part on the overall program. But I think at the end of the day, I think it's more about, do I want to do this at home, or do I want to go to a class? I think that's basically the choice that it looks like they're making. But I agree with you. I'm not sure that we really, I mean, I think we'll be able to look at it down the road, but at this point, I don't think that we really know.
Yeah, I was thinking, as some kind of an exit interview, you could ask them, did you choose the thing you thought you were getting into? Did it fit with what your preference seemed to be?
That's right. That's a great that's a great idea. Mm-hmm. Now that is. Yeah, because I think it will be, it will be very interesting to look and see, and it might be a potential. You could even look at that as a potential, either mediator for the intervention effectiveness, right? When you look and see, it's like, well, did you choose? Did you get what you think you were choosing? And then, if people say, well, not really, I thought I was gonna get something, and this was completely different. If I had known, I would have picked the other one, and those kinds of things. Then we can look and see if that is impacting, how well people did in the program as well. I think that would be very interesting.
Mm-hmm.
We are almost out of time for today's call. If anyone has one final question that we could answer within the next 30 seconds, feel free to ask it. Okay, hearing none, we will thank you so much, Fabio, for sharing this presentation. We will take the recording and make it into a video for our homepage yet again. And Fabio is just going to check our chat box. Nobody had sent a chat for us to address. And thank you, and have a wonderful Wednesday wherever you are across the nation and in the world.
All right, thank you.
Thanks.
Uh-huh.
Bye, everyone.
Bye.